Good morning to all. Today we are going to see about the condition Hirschsprung disease. Hirschsprung disease is also called as a congenital aganglionic megacolon. It is occurs due to the congenital absence of the parasympathetic aganglionic cells both in the muscular layer and the submucosal layer of the distal part of the colon and the rectum. So here the absence of aganglionic nerve cells in the layer of distal colon and then the rectum. So here the which is result in the extreme dilatation of the colon. It is involved in the varying length of the colon. Okay, so next we are going to move on the incidence. Here the incidence occur 1 in 500 live birth, more common in male children than female. Okay, next pathophysiology. Already we know about that there is an absence of ganglionic cells. It is lead to the lack of peristalsis movement in the affected portion of the colon. Which part of the colon? So it is lead to the absence of affected part of the colon cause the lack of peristalsis movement. So here the functional obstruction of the colon will be occur. So here the accumulation of the gas and fecal matters will be accumulated there. So here the enlarged colon will be there. So it is called the Hirschsprung disease. Next we are move on the clinical features. So here those who are having the Hirschsprung disease, these symptoms can seen in the infants and the neonates, especially in neonates and infants. We can see in failure to pass the macron, abdominal distension within 1 to 2 days after birth, bile stain vomiting. If the baby newborn in vomit, and we can see in the bile stain vomiting, and then the enterocolitis, and then due to the fecal stagnations, and enterocolitis mainly due to the dehydration, and then sepsis will be we can see in this. These are the symptoms we can see in the neonates and then infants. Okay, next we will move on the older children, those who are having the Hirschsprung disease. What are the symptoms we can see in these children? So they have in the constipation with abdominal distension due to the mass of the fecus and then gas, foul smell stools, and the ribbon like stools, and the protruding abdomen. These are the symptoms we can see in the older children, those who are having the Hirschsprung disease. And next we are more on the diagnostic evaluation. The suspected babies who have not passed meconium within 48 hours of the birth, those who are not passing meconium after the birth, they are suspected cases. And the non-palpable fecal mass felt in the lower portion of the abdomen, and the next barium enema, rectal biopsy. These are the in diagnostic during in the rectal biopsy it comes to know there is an absence of ganglion cells or mucus. In that biopsy, we can find out there is an absence of ganglionic cells in the rectal or colon. So it comes to know there is the babies having the Hirschsprung disease. These are the investigation we have to do for the Hirschsprung disease. And next more the management. Here the medical management is we can administer the enema, and then administration of stool softness, and the low residue diet. These are the medical management for the Hirschsprung disease. And the next one is the surgical management. The aim of the surgery is to remove the aganglionic bowel followed by the anastomosis remaining portion. So which part of the already we know the distal part of the colon and the rectum may affected with this disease. So end to end anastomosis we have to do. So there is a 2 stages there. One is the temporary colostomy. It's done sigmoid and then transfer colon. We have to do the colostomy. It is enabled to normal distal bowel movement to return in the original tone and size. So we have to know what is meant by colostomy. So the colostomy is an opening called a stoma in the large intestine brought to the surface of the abdomen from the purpose of evacuation of the bowel. So here we are opening the stoma like here in the picture it's show, and there is the stoma will be there. So here we are opening the stoma. It is called surface of the abdomen, that is called the colostomy. So next stage 2, here we are doing the 3 types of surgery, and first one is the Swenson operation or abdominoperitoneal pull through, and second one is the Duhamel operation or retrorectal transnational pull through, and then third one is the Sove operation or endorectal pull through. These are the surgical intervention we have to do. Before doing the surgery, the baby must be completed 6 to 8 months of the age of the temporary colostomy. If we have to do that if you plan to do colostomy, the baby must have 12 to 15 months of age, and 6 to 8 months of age. If they plan to do the surgery, the baby must to complete the 12 to 15 month of age, and then the baby must have the weight of 7 to 9 kg. Or only we can send the baby to proceed the surgical management for this disease. And the next preoperative management, we have to assess the bowel movement, assess the passage of meconium and vomiting, give enema, stool softness, provide the low residue diet, monitor vital signs, monitor abdominal girth, and then give the we have to maintain the semi-follow position so we can prevent the aspirations in children. Frequently we have to monitor the vitals. If their babies having any tachycardia or tachypnea, these are the symptoms we have to assess. What is the type of vomiting, whether the baby is passing the meconium, what is the bowel movement, any high pitch sound are there. These are the things we have to observe in the babies during the preoperative period. And the next followed by the nursing care, with whom we have to withhold the oral feed for sometimes repeat saline enema and bowel wash with the antibiotic solution we have to provide so we can prevent the infection. And then observe the child for preparation complication like the dehydration and the shock syndrome. So frequently we have to administer IV fluid therapy, nasogastric tube aspiration, antibiotic therapy we can provide, and then colonic irrigations with saline, surgical decompression by colostomy. These are the surgical management we have to provide. And then post-operative care include the monitor the vital signs frequently, observe for the surgical site bleeding, monitor the abdominal distension, administer again we have to administer the IV fluids therapy so we can prevent the dehydration, monitor the return bowel sounds. We have to monitor the bowels and provide the colostomy care. We can prevent the infections, keep surgical site clean, and then keep the surgical sites so clean. These are about the Hirschsprung disease. Thank you.